Moving on to lateral elbow, it's very similar to the medial. I like to have the patient set up with the palm on their same side hip. That gives me enough tension on the musculature or the tendon without giving too much flexion of the elbow. Mostly when we're looking at this side, we're looking at the common extensor tendon, which is shallower than the common flexor. We don't need quite this much depth. And again, we're looking for nice linear echo texture attaching to that medial epicondyle. The swale of the lateral epicondyle. The swale of the lateral epicondyle is not quite so deep. It's much more shallow. Again, we can see the radiocapitellar joint on this side as well. Again, if you can't find it, coming down to the muscles, making sure they're nice and linear, and then just following the muscles up. I know it seems silly to say if you can't find it because it's a pretty obvious osseous landmark, but sometimes the easiest things we struggle with. Make sure you slide all the way through it, anteriorly and posteriorly, looking for tendon thickening, hypoechogenicity, or calcification. We want to make sure we evaluate this in short, so if you find it in long, just turn 90 degrees. There it is. You want to make sure you follow it all the way up till that tendon disappears, and then follow it down a little bit. Again, if you can't find it, find the muscle bellies, have your patient wiggle their fingers, and then follow it up. And then that's about it for the lateral elbow, but let's move on to the posterior. Since we often do these together, I'm going to have